It's my honor to introduce Niki, our speaker. Niki Strealy is the owner of Strategic Digestion LLC, which empowers people to improve their digestive health and quality of life through the power of food. Her own personal experiences with IBS and celiac disease have given her a deep understanding and compassion for the challenges faced by people with gastrointestinal disorders. Niki combines evidence-based nutrition strategies with practical solutions tailored to meet individual needs through one-on-one counseling and group presentations. She has over 28 years of experience, and her book, The Diary of a Dietitian: Expert Advice, Practical Solutions, and Strategic Nutrition, was published in 2013. So without further delay, over to you, Niki.
Thanks, Jocelyn. All right, I will get everything shared and we will be on our way. I just want to say thank you, everyone, for joining us today. I know we have so many options for joining webinars, and I know it's hard to do in the middle of your workday or at the end of your workday. So thank you for spending your afternoon or your evening with us. So who we're going to talk about today is teaching the low-FODMAP diet, tools and techniques for patient success. So Jocelyn already gave a nice introduction, so that's just a little bit about me. And my disclosures is that this presentation was sponsored by FODzyme. I have no conflicts of interest, and I'm also employed by Modify Health. So our objectives for today, number one, is we're going to explore the principles of the low-FODMAP diet and its role in managing gastrointestinal symptoms commonly associated with irritable bowel syndrome. Objective two is identify common high FODMAP foods and evaluate appropriate low FODMAP alternatives. Objective three is leverage practical tools and resources to assist patients with meal planning and making informed food choices while following the low FODMAP diet. And our last objective for today is to evaluate the effectiveness of the low FODMAP diet in alleviating patient symptoms and identify appropriate timing for FODMAP reintroduction and diet personalization. So we have a lot to cover. So some things I'm going to go through really quickly, and you'll have to look at them on your resource slides later. But I wanted to squeeze as much as I possibly could in, so just buckle up and we'll get started. This is our agenda. So we're going to first cover the history of the low FODMAP diet, then we're going to assess appropriateness, then we're going to look at FODMAP elimination, reintroduction, and then dietary personalization. We'll kind of take a look at where the research is today, and we'll have some additional, like, where do we go from here kind of steps. Then we'll do a final summary, and we'll finish up with our Q&A. So first, I wanted to lead people through a little bit of the history of the low FODMAP diet. So this is a little bit of a research timeline. So starting back at 2004, the team at Monash University first coined the term FODMAP. And then in 2005, that's the first research article that came out. 2008 was the first randomized controlled trial on the additive dietary effect of fructose plus fructans. 2014, we noticed that they began to notice that there was some possibility of detrimental effects of the gut microbiome for people that were on the long-term low FODMAP diet. In 2018, they started looking at the difference between non-celiac gluten sensitivity and actually realized that it might be FODMAP sensitivity. And then in 2021 and 2022, the two governing bodies for the gastroenterologists, the American College of Gastroenterology and the American Gastroenterological Association, both started recommending the FODMAP diet as primary therapy for people with IBS. So this is, again, a complicated slide, but this really depicts how the certain carbohydrates were studied and connected to IBS symptoms. And as you move through the diagram from the top to the bottom, you can see how the research all came together on these different dietary components to really put together the term FODMAP. In this diagram, you can see on the left how the breakdown of carbohydrates in the small intestine provides a substrate for the colonic bacteria, and that's depicted in the middle of the slide, leading to the production of short-chain fatty acids and gases such as carbon dioxide, like CO2, hydrogen, which is depicted as H2, and methane, which is CH4. Hydrogen sulfide, which is H2S, can also be produced by intestinal microbes, but this is not depicted in this older diagram. On the right, this is the intestine of a person with irritable bowel syndrome, or IBS. This luminal distension can translate to uncomfortable or painful abdominal bloating and a change in bowel habits, such as diarrhea or constipation. So these are some possible IBS GI symptoms, and they include GERD, which is not a typical symptom, but it is something that we do see, and people do mention if you see patients directly. Also gas or wind, bloating, abdominal distension, abdominal pain, diarrhea, and constipation. And just as a reminder that bloating is more like the feeling you have of increased abdominal pressure, whereas distension is the physical growth in the abdominal girth. So that would be where you have those patients that tell you, I look X number of months pregnant. So they might say, I look 5 months pregnant. I've even heard men say, I look 7 months pregnant. So that abdominal distension is just a little bit different from bloating, which is more like a feeling on the inside. So now we're going to assess the appropriateness for the low FODMAP diet. And so the first thing I wanted to cover is let's talk about who's not appropriate for a low FODMAP diet. So, and it's not that this is 100%, but these are some people that I would definitely screen and consider whether or not this would be appropriate. So the first is those who haven't just already tried some simple diet cleanup tactics. So if I have a patient, sometimes we'll start with just some simple things, like we might reduce the intake of lactose or caffeine. We might reduce spicy, greasy foods, highly processed foods, and really look at using more of a whole food diet approach, reducing sugar alcohols. And so I always want to start with the simple things because we don't need to jump to something more complicated like a low FODMAP diet if they haven't really done the first stuff, the easy stuff first. So that would be the first step. The second group are those people with active eating disorder or avoidant restrictive food intake disorder, also known as ARFID. And we'll cover this a little bit more on the next slide. Number 3 is those who are underweight or those who are seeking to lose weight, because we definitely know that the low FODMAP diet is not intended to be a diet for weight management. Number 4 is children. And the reason there's a question mark next to it is they did a systematic review of literature from 2005 to 2021. It revealed that the low FODMAP diet has not been comprehensively studied in pediatrics. The authors of this ESPGHAN position paper concluded there's scarce evidence to support the use of the low FODMAP diet in children with irritable bowel syndrome and no evidence to recommend its use in other gastrointestinal diseases and complaints in children. I typically work with teenagers and older, and I have worked with some families on sort of a modified version of a FODMAP diet because it can be appropriate with maybe some of your older teens, but FODMAP elimination diet as it currently stands would probably not be appropriate for a younger child. The last group is elderly, and again, that's another question mark. It may not be appropriate to give someone that's an older adult a full elimination diet, but I think that's a great opportunity to have this conversation with your patients. So I have some people that will find great relief from their symptoms by just using something called FODMAP Gentle, which we're going to discuss a little bit more in a minute. But again, I have had people, older adults, use a FODMAP elimination diet successfully, but I think it's really up to you to discuss that with your client or your patient and figure out what is the best appropriate move for them. So this is the 9-item avoidant restrictive food intake disorder screen, or NIAS. These are questions that I have as part of my intake form. So this is a validated tool. It's not my tool, but I use it in my screening. And what these terms can put in, so people are going to mark this before they see you, and they can be summed up to calculate a total score ranging from 0 to 45. So if a person marks many of these questions as agree or strongly agree, they're likely inappropriate for a really strict FODMAP elimination diet. Higher scores may actually even make you decide that a referral to a health care provider for possible disordered eating evaluation might be appropriate. So again, this is just a screening tool, but when you see a lot of agrees on this tool, it really should clue you in that maybe a FODMAP elimination diet would not be suitable for this person. So there are some alternative approaches to FODMAP diets, and I decided that I wanted to put these on, I wanted to front load these because there's some new research that's pretty exciting out there, but we're going to cover the FODMAP elimination diet in just a bit. But before we launch into that, I wanted to talk about what some of the research is showing. So this is just a couple-year-old paper, but the typical FODMAP elimination diet, as we know it, uses what's called a top-down or a step-down approach for dietary treatment of FODMAPs, or for dietary treatment of IBS, where they take all the FODMAPs, we remove them, and then we systematically put them back into the diet. And that's mostly what we're using today, and we'll talk about that in more detail later. But another approach that has been proposed and used over the past few years is called a bottom-up or a step-up approach. And what happens is you only remove a few targeted foods or groups. And then the patient is going to work upward to monitor and then restrict additional FODMAPs as needed. So again, we're going to talk a little bit more about this in a minute, but these are two different strategies that can work for maybe certain patient groups. So, for someone that has maybe already removed a couple of the FODMAP groups and they said, I didn't really find a big benefit there, then maybe we're going to do the typical top-down approach. But for someone who maybe all they've done is cleaned up their diet and they come to you and they say, I think I might be lactose intolerant or I might have trouble with garlic, maybe we're going to start with just a few specific groups and then we're going to work upward instead. So the FODMAP gentle or FODMAP light approach has been advocated for many patient groups. A lot of times, as I've sort of been talking about, I'll use this approach with someone that isn't really sure that they're appropriate for the FODMAP elimination diet, or if they think FODMAP elimination might be too strict. I've also used this portion of the diet for people who have inflammatory bowel disease with some IBS overlap. So what ends up doing is, so I have this on a handout and I will say, okay, if these are foods on the left that you typically consume in your diet, then maybe choosing some of the foods off the right-hand column might be a better fit. So if someone is typically eating a lot of apples or pears, then maybe we want to say, like, could you, eat more green bananas? Could you use papaya? Could you use pineapple? Could you use blueberries instead? And so this is more of a swapping approach, but it seems to work pretty well for a lot of different people. So last fall, our friends at Monash put a version similar to this on social media. It's an even gentler style of the FODMAP diet that we just saw in the last slide. I just called it ultralight for today's presentation. I think it's what they call their FODMAP gentle or their FODMAP light. But this again may be suitable for people like children, older adults, where it's really just removing a couple of the major FODMAPs and limiting those rather than doing the full elimination. But again, this takes foods out of the diet, but it doesn't tell you what to put in. So that previous slide, I think, might be helpful for some people, because if you just take a lot of stuff out, they need to find out what they should eat instead. So this is some new research, and this has really just been out this last month's issue of the Clinical Gastroenterology and Hepatology Journal. So you're going to see a couple of studies from that today. So this is really brand new research. It's literally just been out for this past month. So I'm going to do my best to kind of summarize what these studies are showing. So in this particular study, there were 35 patients with IBS-D. They were randomized to two different groups. The low FODMAP diet, or FODMAP simple, where only fructans and GOS were eliminated, and we'll talk about what fructans and GOS are in just a little while. But it's important to note that in this study, there was actually a 31% dropout rate, and most of those patients came from the traditional low FODMAP diet. So fewer patients in the FODMAP simple diet actually dropped out. Both groups had a similar reduction in abdominal pain, bloating, and discomfort. And even though it was not statistically significant, the stool consistency improved at a higher rate for the traditional low FODMAP diet than for FODMAP simple. So it was interesting because that was not statistically significant. But if this was a group, in my mind, this is a group of people with IBS-D, and 31.3% of them felt better, their stools were much better with low FODMAP traditional versus the FODMAP simple, that could be the difference in a lot of bowel movements in one day. So I would also say, keep in mind, what is this person coming to you for? Is it for bloating? Is it for pain? Then maybe removing a couple of FODMAPs might make sense. But if they're coming to you because they're having, 7 to 9 stools a day, maybe this approach wouldn't be quite as good for them. So they concluded from this diet that a simplified version of the low FODMAP restriction focusing on only 2 FODMAP groups is feasible, well tolerated, and improves abdominal symptoms in most patients with IBS-D. It is likely that any differences in clinical outcomes between the groups could be mitigated through the gradual restriction of additional FODMAPs after assessing the initial response to the FODMAP simple. So they were advocating for a step-up approach, which is what we saw a couple of slides ago. So that is another approach that we're seeing used more and more. And again, this is just a research study that came out from Dr. Che's group this month. So now we're going to move to what we think of right now as our traditional FODMAP elimination diet, because again, the research isn't showing quite yet that it's time to just use that step-up approach. So if we're using our traditional top-down approach, these are the kinds of things I'm going to talk about with my patients. So if you take care of IBS patients, and I'm assuming that at least a good percentage of you do, I want to set realistic goals about what to expect from this experience. So sometimes patients come in and they passionately want to try a low FODMAP diet, but often I want to slow them down. I want to make sure that this diet is right for them. So they may have heard that randomized comparative trials show that the low FODMAP diet leads to clinical response in 50 to 80% of patients with IBS. And so they may come to you and say, like, I want this diet. And so sometimes our job is actually to put the brakes on a little bit and make sure that this diet is appropriate for them. So if this was our live presentation, I would look around the room and I would say, how many people have had your patients come in with a one-page low FODMAP diet from their doctor's office? And I would see a lot of people hold their hands up, because this is an example of a one-pager that they got from their doctor's office. And this actually, honestly, is a little bit better than some of the one-pagers I've seen. But we are perfectly able to help our patients really identify what are FODMAPs? Where are the FODMAPs in their diet? Because a one pager like this is going to be really difficult to follow. And so that's why I think that it's really important as we as dietitians are educated on the low FODMAP diet, so we can help our patients rather than just having to eat this and don't eat that list. We're going to be able to really tease out those nuances. So on my intake form, this is something else I have on there. I have these questions. This is the IBS symptom severity score, otherwise known as the IBS SSS. The questions are all rated 0 to 100, except question number 2. They're going to rate the number of days with pain from 0 to 10. You can take the number that they give you, and then you multiply by that by 10 to get a score between 0 and 100. Question 4 is actually a backwards question. So it says, how satisfied have you been with your bowel habits? So if you were very satisfied, what I say is you have perfect poops, you would give it a 0. And if you had terrible poops, you would give it 100. So if you took all of these numbers and add them together, if they had the worst of everything you could possibly have, it's going to add up to 500. So 500 out of 500. So this is a little bit more of a breakdown of what it actually means. So if you have an IBS SSS of less than 75, that's considered remission. 75 to 175 is considered mild IBS. 175 to 300 is moderate, and over 300 is severe. So in that first visit, if I'm going to talk about the low FODMAP diet with patients, and I think that they're appropriate, these are the types of things that we're going to talk about at that first visit. We're going to define what FODMAPs are. We're going to talk about the pathophysiology and what the common symptoms are. We're going to introduce the 3-phase plan. We might talk about how we came to these recommendations. We're going to review the dietary sources of FODMAPs. And then the very last thing that we have to do is we need to provide resources, because if we don't give them resources, it's going to be really challenging to help those patients to be successful. So when I'm explaining FODMAPs to colleagues or when I'm explaining them to patients, this is some of the verbiage that I use. So what are FODMAPs? So they are short chain carbohydrates, sugars, starches, and fiber that are not completely digested in our intestines. As FODMAPs move through the small intestine, water is pulled into the digestive tract. In the large intestine, microbes rapidly ferment the FODMAPs as fuel to survive, creating gas. Excess gas and water in the intestine causes it to stretch and expand, which can be very uncomfortable or painful. Those with irritable bowel syndrome, or IBS, are known to have a highly sensitive digestive tract. Symptoms of gas, bloating, diarrhea, or constipation can result. And one thing that I think that my patients find helpful is that I explain to them that people with IBS actually, the pain sensors are a little bit different in their body. So their brain registers gas and air and water in their digestive tract as pain differently than people without IBS. So people without IBS, they did these studies like 20 years ago. They inflated a rectal balloon. The people without IBS, they did a PET scan. The PET scan was completely normal. The people with IBS, when they did that same PET scan, it lit up the pain centers in their brain differently. So we do understand that 2 people can eat that same bowl of baked beans, and the person without IBS will have the same amount of gas in their intestines, and they don't feel it like the person with IBS. So that sensitivity, that visceral hypersensitivity, is one of the hallmarks of IBS. So this is just a little bit of a different picture that kind of depicts what I was last talking about. So in our small intestine, we have the FODMAPs. They make their way to the large intestine, where we have luminal distension, microbiota alterations, and that visceral hypersensitivity, which leads to gastrointestinal symptoms. So what is the low FODMAP diet? Well, let's talk about the FODMAP acronym. So FODMAP stands for fermentable oligosaccharides, which is an umbrella term for two subtypes, one called fructans and one called galactans. Now, for whatever reason, some people call it fructan and some people call it fructan. So I say it's like tomato. And then galactan is the other portion of the oligosaccharides. But when you see them abbreviated, primarily you're going to see fructans and you're going to see GOS or galacto-oligosaccharides. Again, I don't know who decided to abbreviate one and not the other. It could be FOS and GOS, but we don't typically see it that way. So just as an FYI. So for the D is disaccharides, and we're talking about lactose specifically. And for monosaccharides, we're talking about excess fructose. And fructose is found in a lot of fruits, but it can also be found in honey. And so it really has to do with the ratio of fructose to glucose. So I talk about that a little bit with my patients. A is for and P is for polyols. So polyols are also known as sugar alcohols. They're found naturally in fruits and vegetables in the forms of sorbitol and mannitol. And then we also have the manufactured form, and I talk about that with my patients as well. So the manufactured form could be xylitol with an X. It could be sorbitol. It could be isomalt. And it's often found in chewable candy, chewable gum, and then also medications like cough syrup or a lot of vitamins like vitamin C. A lot of times the first ingredient is sorbitol. So that's a little bit about the acronym. So how do FODMAPs cause symptoms? So certain FODMAPs are known to cause more gas and bloating from bacterial fermentation, like the oligosaccharides and lactose, whereas fructose and polyols are known to pull water into the digestive tract. This can cause diarrhea for those with a fast-moving intestine, but for those with constipation, it can feel more like they have a water balloon in their belly. So the FODMAP elimination diet, how does it work? So we use a three-step process. So we first eliminate FODMAPs from the diet for 2 to 6 weeks. Most people will notice a decrease in symptoms in the first week. Then we reintroduce FODMAPs back into the diet in a methodical manner, noticing any increase in symptoms. And the last step is that we personalize the diet, moderating intake of FODMAPs to manage symptoms. So we're going to go through all those steps today. So this is just a little bit, I mentioned earlier that both the AGA and the ACG recommend FODMAPs, the low FODMAP diet. And again, this is information from 2021 and 2022. So it may change as the research is evolving. But on the current research guidelines, they say of the available options, the low FODMAP diet is currently the most evidence-based dietary treatment choice for patients with IBS. And then from the ACG guideline, it says, in summary, this guideline committee believes that the complexity of the low FODMAP diet, combined with the potential for nutritional deficiencies, and the time and resources required to provide proper counseling on the free phases of the diet, requires the services of a properly trained GI dietitian. And I highlighted the C there because you know, and I know that a little part of me died inside when I saw the C in that, because obviously a dietitian was not on this committee or that would have been caught. But I do like that they're supporting us as GI dietitians. So these are the FODMAP strategies that we want to look at. So there's a couple of different teaching strategies, probably just going to really go through one of them today, but I just wanted to talk about what are some different ones that you could use. So the first one would be that we're going to review the current diet. We're going to replace those high FODMAP foods with low FODMAP foods. I use my intake form, which has a 24-hour diet recall. And so I might go through that 24-hour diet recall with someone and say, these are the places where I see FODMAPs in your diet. These are some swaps that you could make in order to make your diet lower in FODMAP. So that would be one strategy. Strategy number 2 is I also have a slideshow I can go through with food groups. So it goes through like breads and starches, veggies, fruits, dairy, and then I can really show them which ones are some better choices and which ones should be limited during FODMAP elimination. Where the last option, which is the one I'm really going to show you today, which is where I provide lists of foods in various FODMAP subgroups. And that is another strategy that can be used. One important note that I mentioned is that when patients with constipation come and see you for a FODMAP elimination diet, we've noticed that when they reduce some of those plant fibers, they often are increasing some of the starchy carbs like rice and potato. So maybe they were eating a lot of sweet potatoes with the skin and now they've swapped and now they're eating a little bit more like white potatoes. This can actually increase their constipation. So what we're trying to encourage people with constipation to do is to make sure they're consuming plenty of those low FODMAP or lower FODMAP veggies salad greens, cucumbers, carrots, things like that. And then also make sure that they're drinking plenty of water to kind of offset the chance that they're going to increase their constipation. So when we talk about FODMAPs, it is a lot more than just eat this and don't eat that. So portion sizes matter. A small amount of a food may be tolerated, but a larger amount might not be. The Monash app uses a red light, yellow light, green light system. And one thing that you'll notice is that when you use that kind of system, like 20 almonds will be a red light, but 10 almonds is a green light. So not all foods will have a red or a yellow and a green, but it's helpful to really be able to pay attention to how many FODMAPs can I eat or how many almonds can I eat without causing symptoms. We try to keep all those portion sizes really in those like lower green light amounts. So something else that I explain with these details, because the nuances, again, of FODMAPs can really make a difference. So like, for example, FODMAPs are water soluble, but they're not fat soluble. So if you try to take onions or garlic and you try to simmer it in a soup and then you try to take them out, then it's too late. So all of those FODMAPs have leached into that cooking water. But since FODMAPs are not fat soluble, you can take a garlic clove and put it in olive oil and you can get the flavor of the FODMAPs, but not actually get the FODMAPs themselves because they're going to stay inside that garlic clove. So a lot of people will just use garlic infused oil in their cooking, which is really helpful because you can get the flavor again without the FODMAPs. And then I also explain when it comes to the onions, the green onion tops will be a green light, so you can definitely use the green onion tops, but the bulbs are where the FODMAPs are located. So I'm always trying to give those like little details, especially people that like to do a lot of their own food prep. Ripeness can make a difference. So like when it comes to bananas, yellow spotted banana is higher in FODMAP and a green just turning yellow banana is lower in FODMAP. So again, sometimes it's the food, sometimes it's the ripeness of it. And then also, I always tell people that cooked foods are going to be better tolerated than raw. So if you have somebody that has a really sensitive digestive tract, cooked foods are going to be more easily digestible. And so we'll start with those if we can, especially if someone is particularly sensitive. And then what's interesting is Monash will update the content of foods periodically. So there were times where we used to say they could have as many strawberries as they want. And now we found out that they can only be limited to like 5 strawberries at a time. And so one of the things that was really interesting is they said that as they've updated the FODMAP content of foods is that some of the FODMAP or some of the foods themselves have changed because of drought conditions and because of climate change. So it's really interesting that they've been testing FODMAPs now for about 20 years and that the actual FODMAP content can be different. And then lastly, the high FODMAP and low FODMAP foods aren't always intuitive. So I tell patients, we're always looking at, people always lump together cauliflower and broccoli. They come together in the bag in the freezer and people are like, oh, I can't have cauliflower and broccoli. And I'm like, well, did you test them separately? Because we know that cauliflower is higher in FODMAP and broccoli is lower. But to get more specific, it's the broccoli heads that are lower, the stems are higher. So we really need to pay attention to some of those details. And then to tell them it's not intuitive, I say, then you say you have broccoli where the heads are high and the heads are low and the stems are high. If you look at broccolini, then it's actually the opposite. So the heads are high and the stems are low. So again, you can't always guess what's going to be high and low FODMAP. So it's not always intuitive. So when I talk about FODMAPs, I also talk about this concept called FODMAP stacking. So I use this used with permission from our friend Patsy Katsos. And so FODMAPs are these sugars and fibers in your diet. All the FODMAPs from your diet go into the same bucket. So we see that FODMAPs have like this accumulative effect. And so if someone is consuming too many green light servings of foods all at one time, they can still get some effects from that. So for example, if I have somebody that has like a fruit smoothie and they put 5 green light, low FODMAP fruits in that same smoothie, they can still get symptoms, even though they think they're on a low FODMAP diet. So I'm not saying this to freak patients out. I'm just, cautioning them that you can have too many green light foods. And so one way to be a little bit more careful of that is fruits in particular tend to add up more quickly when it comes to FODMAP stacking because fruits are so high in carbohydrate versus like vegetables, which we know are lower in carbohydrate. So I know that's kind of confusing. I'll spend some time teasing that out with patients if they have more questions. But if you want to, you can also click on that link at the bottom and that will take you to a better probably explanation of what FODMAP stacking is and how to avoid it. And just the other thing too, I guess I'll say is that the collective reduction in FODMAPs is really our ultimate goal. So we don't want to get caught up in all those little minutia, because I know our IBS patients love black and white thinking, and FODMAP is not so black and white as that. It really is like, let's reduce the total intake of FODMAPs. So this is a handout that I will often use for patients. I was mentioning those different strategies, teaching strategies. So this is just an example of a slide where I put all the fructans on one page. And so what the patient and I would do is we would go through what they typically eat, and then we go through and highlight. So these are some of the foods that I typically eat. Now there's foods in here that are lower in FODMAP. There are foods that are higher in FODMAP. And so we're going to pay attention to which ones are green light foods, which ones are yellow light foods. But I want to make sure that we're identifying where the FODMAPs in their diet are coming from, because that's the most important thing. I mean, you could talk about, reducing your intake of rye bread, but if they never eat rye bread, then that's not, that they don't really care about that. So we're really trying to personalize the diet for them. One thing I do explain too in talking about fructans is that people often get fructan and gluten mixed up. So as I explained, so I have celiac disease, and celiac disease means that I can't have any gluten. So gluten is a protein found in wheat, rye, and barley. And interestingly, wheat, rye, and barley are also high in the carbohydrate form, which is the fructan. So when someone says, I feel better when I don't eat pasta, they may assume that it's the gluten that's making, them feel terrible. So when they take the pasta or the bread out, they're like, oh, I feel better. But what I explain is it may not actually be the fructan, or might not actually be the gluten, it might be the fructan, which is the carbohydrate component of that same pasta. So sometimes we have to talk about that a little bit. And, as such, people what are following the IBS low FODMAP diet can often tolerate sourdough bread, because sourdough bread has been pre-fermented. So the fermentation has happened at the bakery, so that by the time they bake that bread, it's now low in FODMAP, but it does remain high in gluten. So someone that is like, I don't know if I have a gluten problem or a fructan problem, if they tolerate sourdough bread, often it points more toward a fructan or an IBS issue, versus if someone has celiac disease, then they're going to be intolerant to any amounts of gluten, even from sourdough bread. So the GS group is primarily beans and nuts for my patients who are vegan and vegetarian FODMAPers. I actually have a separate handout that I use that has different protein options for people on a vegan or vegetarian diet, because, like, let's be honest, these are the foods that they're using as their primary protein sources. And so they're kind of like, how much can I have of these protein sources in order to, meet my nutrition needs while not going too high with the FODMAPs? This list includes higher lactose foods. So lactose-free milk, ice cream, cottage cheese, and lower lactose foods like cheese are allowed on the FODMAP elimination diet. Those with a dairy allergy or on vegan diets may prefer using plant-based milk, yogurt, cheese, etc. Harder cheeses and things like half and half and sour cream are lower in lactose, and those can be used while on the elimination diet. And this is just a list of some foods containing excess fructose. And then these are foods containing sorbitol, and then on the right, foods containing mannitol. So a question I get a lot is, are there any free foods on the FODMAP elimination diet? And the answer is, well, kind of. So remember, the main goal is to reduce our total intake of FODMAPs. This is a low FODMAP, not a no FODMAP diet. But these are some foods that can generally be consumed in higher quantities pretty safely without causing a lot of symptoms. So we've got these at the top, so you can look at those. And then the foods that are just fat or protein, then those can usually be tolerated at higher amounts. So that could be beef and pork and lamb and poultry and fish and shellfish and eggs. But again, it's the sauces or the gravy or the marinades that we put on top that typically bring the FODMAPs. And so we're going to be a little bit more careful about those. That's why I put in there simply prepared. And it's probably going to be like salt and pepper, a little bit of lemon juice, adding some spices, adding some paprika, adding some cumin. Those kinds of things are going to be allowed. So I educate my clients about the low FODMAP apps and food scanning apps. I provide lists of websites with recipes and names of companies that provide low FODMAP food products to make their lives easier. I also talk about companies that provide meal plans and delivery meal service. This could be a really simple solution for those who don't like to cook or people who like to eat out a lot. I saw a patient last week that literally eats out 3 meals a day. And so those are the kind of people that talking about how to make a low FODMAP meal, maybe they don't really care because they're going to buy all their meals. And so being able to offer them a resource like that is helpful. And then there's also the low FODMAP dietitian training, which is available. And I feel like that's a really helpful thing as a dietitian. If you're going to be treating people or working with people who have IBS on a regular basis, you want to make sure you have adequate training, because today is really just like a superficial run through of, as much as I can fit into today, but really longer, more robust training is really great. So one thing I mentioned earlier is that I have handouts that I give out to my patients. And what happens is patients will say, do you have a handout for that? Like, do you have a handout for beverages? And I'll be like, oh, yeah, I should probably create a low FODMAP beverage handout. So you may find that your patients ask you certain questions and then you're like, oh, I don't think I have a resource for them. Then you need to do the research and put it together and create some resources. But it can be really helpful because then they have something that they can print out, they can put it on their fridge, and then they can really be able to use those resources while they're following the elimination diet. So for the 15 years I've been teaching this diet, I've realized that my IBS patients, they love, I mentioned earlier, these eat this and don't eat that lists. Why a lot of the resources I offer to my patients do have lists. I also remind them that they don't have to be perfect for this diet to reduce symptoms. And so I tell them the most important thing is that your tolerance to a particular FODMAP is what really matters most. So you're going to see something on a website or on a chat room or whatever, but really ultimately I want to personalize this for that particular person that's sitting in front of me. Okay, so let's say you found your person was appropriate for the FODMAP elimination diet. You gave them the education and the teaching and all the resources, and then you sent them on your way. So now it's time for a FODMAP reintroduction. So after the elimination, I'm going to bring them back in and I'm going to have I'm going to get an updated IBS SSS. And interestingly, generally speaking, the literature mostly recommends, or they're hoping for, a decrease of 50 points in the IBS SSS between the elimination and this next visit. But I would say a lot of times I see 100 or 150 point reduction, and it's really exciting. You'll see someone that comes in that severe category. Maybe they have an IBS SSS of 350, and they may come back to you and the number is like 110. And they're telling you, I feel amazing. And you're like, yeah, I know, like this is a really good sign that you're feeling better and this FODMAP elimination has been beneficial for you. So when I bring my patients back, this is kind of my own formulation that I came up with, but I want to find out, what did you think? Did this diet help you? So I tell them based on their answers, we've got 3 different doors that we're going to use moving forward. So I say, okay, so door number 1 is I tried this diet to the best of my ability. It did nothing for me. And we know that up to maybe even 50% of patients don't find benefit from the FODMAP elimination diet. We'll talk about some other ideas on what to do about that later, but sometimes you will get that answer from patients. And then door number 2 is someone says, I tried this diet, I did it to the best of my ability, it really helped my symptoms, and I'm ready for reintroduction. And door number 3 is I tried this diet. I don't know if I did it right, or I didn't follow it, or I went on vacation in the middle. My symptoms have improved, but I want to wait another 1 or 2 weeks on the low FODMAP diet to see if I feel a bit better before beginning reintroduction. So one thing I wanted to point out is that all 3 of these doors do lead to reintroduction. So we don't want our patients to get stuck on the elimination diet. So door number 1 is we're going to say the FODMAP diet didn't work for you. Let's go a different direction, but we are going to reintroduce FODMAPs back into their diet. We might do it in a little bit of a reintroduction pattern. We might just abandon it completely, but we're definitely bringing foods back in. Door number 2 and door number 3, we're still going to do a form of reintroduction. I'm still going to give them the teaching on the reintroduction. But the question is, are they starting reintroduction today, or are they going to start it in 2 weeks? So I don't leave the option open for them just to say, oh, I'm just going to stay on this diet, because that's not our recommendation. We want them to definitely go through reintroduction. Okay, so I know this is another really busy slide, but I wanted it to be all in one place for you. So these are the guidelines that I have on my reintroduction handout for them. So I'll just kind of go through the guidelines. So number one is you're going to continue the FODMAP elimination diet while reintroducing one FODMAP each week. Number two is only choose foods from the reintroduction guide because they contain only one FODMAP subtype. Number three is as FODMAPs are tested, do not add them back to your regular diet, even if it does not cause symptoms. And I tell people that's probably the hardest thing to do because if you find out that you tolerate garlic, I totally get that you want to leave garlic in your diet. But then if you leave garlic in and then you test onions and you have a reaction, it's like, well, is it the onions plus the garlic? Is it the new thing you just tested? It makes it unclear. So I tell them just to remove the variables, you got to take it back out, even if you feel awesome when you ate it. Number four, test the challenge food all 3 days in a row, increasing the portion size each day, followed by a 2 to 4 day washout period. And I tell people that if they didn't have any symptoms, so they reintroduce something, they can just wait like 2 days or so, and then they can jump into the next reintroduction. But if they get severe symptoms, they may want to wait those 4 full days until they begin the next reintroduction. Number five is track your progress and record symptoms. And I tell them, I don't care how you track it, just be able to bring that back with me so that I can help you with personalization. Number six, limit variables when possible. Wait to challenge foods if traveling sick or very stressed. Number seven, anticipate minor feelings of gas bubbles and bloating, normal when adding back foods with fiber. Number eight, if severe symptoms are experienced on any test day, stop that challenge. So sometimes I have patients that make it to day 1 or day 2, and that's as far as they get. And then day number 9, tip number 9 is consider retesting a different food in the same subgroup if the reaction is unclear. And number 10 is don't lose hope and don't give up. The reintroduction process can take 8 or more weeks. The information learned helps tailor the long-term diet. So definitely people will sometimes get burned out on the reintroduction. And so I want them to feel like it's okay to take breaks in the middle, but that ultimately we still want to get to that endpoint, which is that they reintroduce everything so they really have an idea of how food behaves in their body. So this is just a brief reintroduction. What I have them do is I have them choose the FODMAP group and the food that they want to reintroduce. Like they may say, I'm going to do sorbitol as the subgroup, and I'm going to choose blackberries as my food. They're going to test that same food all 3 days, and they're going to consume that food all at one sitting. So we've got day 1, they're going to add that food in with their FODMAP elimination diet. We're going to evaluate it. Day 2, if they did pretty well, they're going to use that test food again, but a larger portion size. And day 3, if they did okay with that, they can increase it again, or they can keep it as the same portion size. They don't need to eat more than they would normally consume. So I tell them that because the day 3 amount of almonds is really high, which you'll see here in just a minute. Okay, so now we've got our FODMAP challenges, and we definitely, it says, it is recommended to test these fructans over 3 separate weeks. So some dietitians I know combine garlic and onions, and they'll just say test garlic and onions as one reintroduction. But I found, this is just me subjectively, I haven't seen this in research, is that probably about 80% of my patients have a clear distinction between whether they tolerate garlic or onions, or both, or neither, different amounts. And so I feel like it's really important to separate those out because garlic and onions are everywhere in our food supply. So I'm like, you would want to know, can you do garlic and not onions or vice versa? I think it's important. And then wheat pasta gets its own separate test as well. And you can swap out bread instead of pasta if they want to do that. And for the GOS group, you'll see that the test groups are the test foods are almonds or chickpeas. You can see day 3 for almonds is 30 nuts. And I tell people I would never eat 30 almonds all at one sitting. So I'm just going to pick the most of whatever I might eat, which would be like 25 almonds or 23. So I tell my patients to do that too. And then for lactose, we're going to do skim milk or plain yogurt. And I tell them that the reason we use the lower fat milk or skim is because fat can cause GI problems for some people. So if they don't tolerate whole fat milk, I can't tell if it was the fat or was it the FODMAP, the lactose that was causing the problem. So that's why we use the leaner or the low fat milk. And we've got our choices, our 3 choices for the excess fructose. And then for sorbitol, we've got avocado, and then we do that separately from blackberries. About a year and a half ago or so, the folks at Monash determined that avocado actually has its own type of FODMAP. It's called persitol, and so far it's the only one they know that has persitol. So they realized that avocado and blackberries can't necessarily be swapped in and out for each other. So if you tolerate blackberries, it doesn't necessarily mean you'll tolerate avocado and vice versa. So we actually asked them now to test those as two different separate tests. And here are our choices for mannitol. So I always remind my patients that our overall goal for reintroduction is to determine your tolerance to individual FODMAP groups, expanding your diet to the widest variety of foods while minimizing symptoms. Our job as dietitians is to provide encouragement and support for the reintroduction process. And that's really important for your patient success because a lot of times these patients will come in and they have felt miserable for years sometimes. And then when they go on the FODMAP elimination diet, they feel better for the first time in a long time. And they're like, I don't want to go back to that. And so they're like, I love the FODMAP elimination diet because I feel good and they want to stay there. And so our job as dietitians is to encourage them to move past this elimination diet, to put FODMAPs back into their diet. And so we're going to talk about what that looks like long-term in a bit. But it really is important to have that relationship with your patient so they can trust you and that they know that, you have their best interests at heart and you want them to feel good long-term, but you also know that they need to get those important fibers back into their digestive tract. So when they're reintroducing FODMAPs, they're possibly going to have some symptoms. And so I want them to have some tools available that can help mitigate those symptoms. So I tell them, discuss this with their medical provider or pharmacist. Some of these are over the counter. Actually, they're all over the counter, but some of them are more medicinal and some of them are more herbal. And so I feel like there's some really great things out there that can be helpful for people. And I'm happy to talk with people more about the specifics on these. They all have a little bit different benefit, but I think it's helpful, again, to have these available in case they need them. So as I've said, we don't want them to get stuck on the FODMAP elimination diet, sometimes because it feels safe to them. It's our job to support and gently nudge them toward reintroduction. And that's why I think it's important to have a check-in visit about 4 to 5 weeks into the reintroduction process to really just see how they're doing and to really give them encouragement. And, if that means accountability, that means accountability. We're keeping them moving forward on the reintroduction. So a question I get sometimes from patients before they do the reintroduction and sometimes after, but what if the FODMAP elimination diet doesn't work? Like, what do I do? So I'm going to ask questions of the patients. I'm going to find out, did they do the diet correctly? Did they have COVID in the middle? If it's a woman, did she have her period in the middle? Did that mess things up? And sometimes we need to go back and kind of talk about the diet a little bit more, where they accidentally FODMAP stacking, because that does happen sometimes. And then sometimes we just need to refer them back to the GI or the PCP, because that, occasionally happens. So I had one patient years ago that was having like 15 stools a day and had come to me for FODMAP elimination. And they did that and came back to me and they were like, I'm not really feeling any better. And they didn't really have any red flag symptoms, but I was like, there's still something going on. And so I said, I think it's really important that you go see a gastroenterologist, which of course takes a long time to get in to see. And they went and saw the gastroenterologist. And then they ended up getting diagnosed with ulcerative colitis. So I feel like, trusting that judgment, that FODMAP elimination can be helpful for some people, but always trust that judgment. If there's something going on and you feel like there's something we're missing here, please send them back to their provider for additional testing if needed. Okay, so I'm gonna take a drink before I launch into this. I know it's another busy slide. So this is another recent paper, but just from last fall. So this was on 117 patients undergoing a 9-week blinded FODMAP reintroduction. The elimination diet improved symptoms in about 80% of the patients. Interestingly, the most prevalent triggers were identified as fructans, mannitol, and GOS. And then over here, they had lactose, fructose, and sorbitol. And then interestingly, they also tested for glucose. The symptom recurrence was triggered by an average of 2.5 plus or minus 2 different FODMAPs per patient. So I thought that was really interesting. And that in their conclusion, They said that mannitol and fructans were identified as the most prevalent triggering FODMAPs in this IBS cohort. However, the very heterogeneous and individualized pattern of symptom recurrent patterns precludes the concept of focusing only on these two categories when embarking on a low FODMAP diet. Selectively eliminating only these FODMAPs would lead to missing out identifying additional FODMAP triggers in patients. So we're hearing two different sides of the research. One side is saying maybe we should only be giving people the bottom-up approach with two FODMAPs to eliminate initially. And then this group was saying, like, we think that these people would have missed out on a bunch of their FODMAP triggers if we had done it with that type of approach. So that was one viewpoint. And then this also came out in this month's published edition of the Clinical Gastroenterological and Hepatology Journal. So this was 45 patients underwent a FODMAP elimination and reintroduction, and the findings are that 25 patients, or 45%, had improved abdominal symptoms. So that last group was 80%. This group was 45. That had a larger sample size. That was 117 patients. This was 45 patients. The most prevalent triggers in this group were the fructans and the GOS. And the symptom recurrence of pain and bloating was triggered by an average of 2.55 different FODMAPs per patient. So that last study was 2.5. This one was 2.55. So that's very, very consistent. But one of the things I wanted to point out was very interesting in this study is that on the fructan reintroduction, the pain was reduced when fructans were introduced later in the process. So this is just brand new information. And so I think that might be something that I talk with my patients about with FODMAP elimination or reintroduction. I might start asking them to bring the fructans in later in the process because I don't know, maybe there's something to it. But the conclusion said, our results suggest that the reintroduction of select FODMAPs may be responsible for symptom generation in patients with IBS who have responded to a low FODMAP diet and provide a strong rationale for performing a future trial comparing the treatment effects of a limited low FODMAP diet with a standard low FODMAP diet. So this group again was saying, hey, fructans and GOS seem to be big triggers. Maybe we would want to do more of a bottom-up approach, just using fructans and GOS moving forward. So we're seeing these different sides of the research, and I found that it was really interesting. And I think as dietitians, we're going to see some more of this in the next few years. Okay, so your patients have done elimination, they've done reintroduction, and now it's time for personalization. So these are questions that I ask when my patients come up to me. So come back to me. I say, okay, so what did you learn? Which FODMAP subgroups cause symptoms at what portions? What were your symptoms? Did these symptoms differ between different FODMAPs? How long did it take from the time you ate a food until the symptoms began? And then how long did it take for symptoms to resolve? So something that I've noticed from patients is that they said that after they've done a full FODMAP elimination and reintroduction, they feel like their symptoms are shorter or like they resolve quicker than they used to before FODMAP elimination. So I don't know if there's, I postulate maybe there's a rebalancing of the gut microbiome. It's hard to know, but, it's definitely interesting just as an observation that people seem to recover faster from their symptoms after FODMAP elimination. So for diet expansion, we're going to move, kind of past the elimination, past the reintroduction. This can be done in a stepwise fashion. I have another handout that I use for this, but people do not need to avoid these foods long-term. And I think that's a really important, thing to point out to them. The digestive tract and the microbiome are dynamic. They change all the time. And unless someone has celiac disease or a severe dietary allergy, it may be possible for them to reintroduce these foods down the road. So I'm always saying, if you don't tolerate it now, let's try it again in a few months and see what happens. So we're going to bring those foods with multiple FODMAPs in. We're going to ask them if they're concerned about eating certain foods or if they plan to limit or avoid particular FODMAP groups. Again, we want to encourage them. Try them again in a couple of months. And then our last step could be adding FODMAP enzymes. So this is just a quick picture of what the FODMAP enzymes are. I like to say that they're like scissors. So we've got FODMAP enzymes for the fructan group. We're going to look for products containing fructan hydrolase or inulinase. And as a clinical pro, I'll just say that some dietitians use the enzymes with a FODMAP gentle diet from the beginning. So I've had quite a few patients that don't want to do the elimination diet, and they're pretty sure that onions and garlic bother them. And so this might be a great option for them, is to maybe do some FODMAP swaps and try a FODMAP enzyme. So that could be really helpful. For people who know that they specifically are triggered by GOS, you're going to look for products containing alpha-galactosidase. But make sure to read the brands, because the most common brand that you can find at the local grocery store does contain mannitol. So there are a few brands that do not contain mannitol. Those are the ones I steer people toward, because you don't want to be taking a product for your black beans that cause you gas, and now you have a symptom that isn't clear if it's from the beans that you ate, or is it from the mannitol that's in the supplement you just took? So for lactose, we know we're going to look for products that contain lactase. Again, some of the chewable products from the most common brand do contain mannitol. For fructose, you're going to look for the ingredient called glucose isomerase or xylose isomerase. And sadly, there is no enzyme for polyol. So if you have a sorbitol or a mannitol intolerance or your sensitivity to those with FODMAPs, then right now the only real way of controlling that is to reduce your intake of those, or to really manage how many of those sorbitol or mannitol containing foods that you're consuming. But I am hopeful that someday there will be an enzyme and they'll be able to take that. So thankfully, there are several products that contain enzymes that cover 3 or even more FODMAP groups. And I think that's why it's really important why people do a FODMAP elimination and reintroduction, because then they can say, these are my trigger foods, and they can take an enzyme that's targeted for their specific, FODMAP intolerance. Whereas if you're doing that bottom-up approach and you're kind of guessing that maybe my problem is the fructans and the GOS, and they're like, and I try this product that is where it says it's for FODMAPs, and they don't get an improvement from their symptoms, it may be because they accidentally were, or not accidentally, but maybe they didn't know that fructose or sorbitol was really their trigger. And so they were taking an enzyme that wasn't appropriate for their intolerance. So FODMAP 2025, where are we? Okay, so we're getting toward the end here. So this is another study, or this a summary actually from that same journal. This is this editorial. And so this author pointed out that the low FODMAP diet, proper reintroduction, and personalization is often poorly implemented in clinical practice, leading to prolonged and unnecessary dietary restriction. Be honest, we've all seen this, where people get stuck on the diet for way too long. So the author is very interested in the FODMAP simple diet, where only 2 of the FODMAPs are eliminated short-term, such as fructans and GOS. The author posed some interesting questions that will be addressed in further research. So number 1 is the reintroduction phase applicable to FODMAP simple responders? Number 2, if so, how should reintroduction and personalization be structured? And number 3, should we shift to investigating the mechanisms that underlie selective fructan or GOS associated symptoms? So I feel like these are some really important questions. I think they're going to be really sorting these out in research the next few years. I would just say subjectively, because I've been teaching this diet for 15 years, that when I started teaching the FODMAP elimination diet, I actually started with the bottom-up approach. So I would say, this week, we're going to reduce lactose. And then next week, I'd be like, okay, next week, we're going to work on the fructans, or we're going to take the fruit. And just, again, subjectively, but when I did that, my patients were like, kind of helps, sort of, because a lot of people already knew that they were lactose sensitive. But when I started doing the FODMAP elimination diet, I noticed that patients were saying, wow, this is a really big difference for me. So I don't know if we're ever going to completely do away with the FODMAP elimination diet. I don't think I personally will, unless the research shows that I absolutely should. I feel like it just goes back to that, N equals 1. You look at the patient in front of you and you really determine what is the best course of action for this patient. Do we do swaps? Do we do a bottom-up approach? Do we do the top-down approach? I mean, I think that that's the most important thing with your clinical judgment, is making decisions based on the person sitting in front of you. So for FODMAP 2025 and beyond, where are we? So we've got, if somebody comes back and they say, I felt really great on elimination, I reintroduced my FODMAPs, and every single one brought symptoms back, and I feel worse than I did before. A lot of those people, I'm like, it sounds like maybe we need to do some testing for small intestinal bacterial overgrowth or intestinal methanogen overgrowth. So I'll send people back to their provider for that. We know that there's a certain percentage of people that the low FODMAP diet doesn't help, and it might be that they have sucrase isomaltase deficiency, so they might need testing for that. Some people might need a physical therapy evaluation for pelvic floor disorders. I find that particularly helpful for people who have alternating diarrhea constipation, people who have severe constipation, maybe people who have had multiple abdominal surgeries or who birthed a lot of children or who had twins or triplets. So a lot of those people and some of the people that don't meet any of those criteria will benefit from pelvic floor disorders. Also, not just women, but men too. I have a lot of men that have actually benefited from pelvic floor therapy. We know that endometriosis and IBS are linked, and we're seeing that more and more in research studies. And so I might send them to their OBGYN to have them look for endometriosis. We might have them see a therapist, someone that can work like a gastro psychologist that can work on gut-brain therapies. There are apps available for gut-directed hypnotherapy or cognitive behavioral therapy. So we know from research that the low FODMAP diet helps some people, and then other people are helped just by doing gut-directed hypnotherapy. So we want to make sure we incorporate those treatments if those are appropriate. And then I think somewhere, in the future, we're going to be looking at, can we make the low FODMAP diet even more effective? Can we add prebiotics? Can we add probiotics? Well, they've actually done a little bit of studies there. So they did this one on partially hydrolyzed guar gum, but unfortunately, they used either PHGG or low FODMAP, and they found out that they were about the same. So that wasn't beneficial to do one or the other. But I'm like, what if they had put them together? I think that would be beneficial. The paper on the right studied 43 subjects doing the low FODMAP diet versus psyllium for people with fecal incontinence. Both study groups reported a 50% decrease in fecal incontinence. But again, what if they had added the psyllium to the low FODMAP diet? That might have been beneficial, but we don't know. They haven't done that research yet. So in this study, using the low FODMAP diet and probiotics or low FODMAP diet alone, both treatment groups decreased their IBS SSS by about the same amount. So it's 86 versus 85%. But since half the patients had IBS-C and half the patients had IBS-D, what I found interesting from this study is that this finding supports the argument that a low FODMAP diet can be applied to all subtypes of IBS. So there was a question before whether it was beneficial for only IBS-D, but this particular study, the probiotics weren't that helpful, but they found that the low FODMAP diet is helpful for both types of IBS. This is a busy slide. You can look at it later, but these are just different research studies that have been done that really have shown how the low FODMAP diet can be applied in a lot of different areas. So SIBO, GERD, IBD, endometriosis, performance nutrition, autism spectrum disorder. So I encourage you just to take a look at some of these papers and look at some of this overlap, because we like to think of the digestive tract as just being living there alone in the body, but there's a lot of different places where it can be impacting other diseases and disorders. And we need to be, keeping our eyes open for these other overlaps, because it may be beneficial for some of these other disease states as well. Okay, so to summarize, you're going to evaluate appropriateness with your patients. You're going to start with FODMAP gentle or FODMAP simple. You might try FODMAP enzymes first. Then you're going to educate the patient on the elimination diet. You're going to provide lots of resources. Don't let them get stuck on the elimination diet. You're going to guide and encourage them through the FODMAP reintroduction. You're going to use information from the reintroduction to create a personalized long-term plan. We're going to have them experiment with portion sizes, expand to foods with multiple FODMAPs, and again, try FODMAP enzymes, especially if they find out that there are certain FODMAPs that they don't tolerate as well. We can try some enzymes to try to mitigate some of those symptoms. If the diet's not effective, then we're going to refer them to care providers for further evaluation, like gut-brain therapies, a trial of prebiotics, probiotics, consider physical therapy for pelvic floor disorders. You might have them tested for SIBO or EMA. And with that, we are ready for our Q&A. So, Jocelyn.
Wow, thank you, Niki. That was incredible.
I packed it in.
Take a sip of water. We've got some really good questions here in the chat. We'll hold you maybe 5 minutes longer to answer a couple of them and then up. Here to start, we have a question from Annette asking, can you share advice when working with vegans or vegetarian clients in the past, particularly related to legumes? Are certain legumes higher or lower in FODMAPs, and does cooking technique influence?
Great question. So it's always a challenge. Vegans being more so a challenge than vegetarians, because obviously with vegetarians, we have a few extra options, because like eggs don't have FODMAPs in them. So if they're vegetarian, they can eat more eggs as a protein source. But When it comes to like the vegan options, there are some that are better than others. Like for example, they can use firm tofu, which is great. They can use, almonds and walnuts and peanuts and all the nut butters that go with those. We try to steer clear of the pistachios and cashews. So that means like cashew butter and cashew milk because those are high in FODMAP. So I use the resources out there for the amounts of a FODMAP in those particular foods. Cooking sort of makes a difference, not really with FODMAP content, but certainly like tolerability. So again, we know that a sensitive gut is going to tolerate nut butter easier than it's going to tolerate like a whole nut. We also know that you can, sometimes you can soak beans and you can soak them with a piece of seaweed, and that will decrease the gassiness of a particular bean. We know that like lentils and chickpeas are low in FODMAP, so we're going to choose those over like a black bean or a kidney bean or a white bean. So there's definitely like variability, but it is doable. But they'd have to be with a dietitian because I think it would be really hard to do alone without support. So yeah, that's a great question.
Great, thank you. Here we have a question from Christy. Is there a dosage recommendation for the FODMAP enzymes, or is it just start small and then increase until they get symptom relief, or just follow directions on the bottle?
Oh, it's a great question. I mean, I would always start with following the directions on the bottle. But the good thing with enzymes is that there's really no side effects. So I call it low-hanging fruit. So like if you just take someone that's lactose intolerant, for example, and you give them lactase enzyme, if they take one, then that's not enough. You let them take two, that's not enough. They take three, and that's the right amount. Great, take three. With the ones that are pills, you're going to like dial it up like that. If it's more of a powder, you're going to sprinkle it on your food. You can sprinkle a little bit more. And you know what? Nothing's going to happen if you accidentally sprinkle too much. So that's the good news is the worst thing it's going to do is cost you more money. That's what I say. It's like, it's going to cost more, but it's like, hey, it's worth it.
Great. And then here, just keeping on this theme, we have one more question on enzymes. Are they suitable for pediatric patients?
Yes. Yes, absolutely. I love using the enzymes. Great for pediatric patients, especially for people who like can't do an elimination diet, but you might be able to just sprinkle or take a pill for lactose intolerance or for gas and bloating. You give them something with alpha galactosidase. I think that would be a fantastic option.
Great, thank you. Here we have a question a little bit more touching on the brain-gut connection. Does anxiety around reintroducing once symptoms are better potentially cause some symptoms versus the foods themselves or in combination? Great
Yeah,
question overall.
yeah, that's a great question. And I think, yes, I mean, I have some patients where anxiety causes their symptoms, and I have other people where their symptoms cause anxiety. So we see it going both ways. I do think that's why using some of the breathing techniques like diaphragmatic breathing or box breathing can be helpful. So when people think, am I getting symptoms from this food? Or is it the anxiety around the food? If they can work on the anxiety piece and really help that gut-brain connection, then it can improve tolerance to a lot of foods, which is amazing. So some people will do a practice where they're using like the tools like the gut brain or the gut directed hypnotherapy app. So they can use something like that routinely. They can meet with a practitioner. But I have seen that when people are really getting their gut and their brain to talk, I say play nicely together, that it does improve their tolerance to certain foods. So that's what's super exciting about it is again, doing an app that controls or helps with your gut and your brain. If that helps you to eat more foods, like absolutely, let's do that.
Great, thank you. Here, Sarah asks a great question around timing. So how soon after ingestion of FODMAPs do patients typically notice symptoms, for example, the pain and bloating, for journaling purposes, and of course, learning their tolerance?
Yeah. Oh, I love that. And what I tell people is it's really individual. And what's also interesting is in the research, the timing is different. So for certain FODMAPs, that timing of from the time that they eat something until the time they get symptoms is maybe like 2 or 3 hours. And then for some symptoms, it could be like 2 days later. So that's what's really confusing is that's different for each person. So what I tell people is, when you ate that food, when you put that reintroduction food in. So it's up to you to figure out how long does it take until you get those symptoms. I tell people the time for me personally is 6 hours. Like I know if I eat something that doesn't agree with me because I have IBS, like it's almost like to the minute. 6 hours later is when my body is going to complain about it, and so that's what's helpful for me. But then I had an event like a few months ago where I had something with fructose in it, and it was 90 minutes, and I was like, oh, that was faster than it normally is. So I feel like it's really important to know your own personal body's reaction time.
Awesome. Thank you. And this will be our last question from Nicholas asking, do you require a formal IBS diagnosis from a doctor or GI before you'll assist with the LFD, low FODMAP diet?
In a perfect world, that would be great. But realistically, right now, when people call to get a gastroenterology appointment, it's can be 4, 6, 9 months away. And so I think we as dietitians can do a whole lot of stuff with diet and hopefully to improve symptoms so that maybe they don't even need to go to the gastroenterologist. I mean, unless they've got red flag symptoms, then I'm like, absolutely go to the GI doctor if they're waking up with bowel movements in the middle of the night, if they've lost weight, they have a fever, or they are having blood in their stool. I mean, any of these red flags, I'm like, go to the GI. But if they're coming and they're like, I have gas and bloating after I'm eating, or I have pain, or I have diarrhea, or I have constipation, I feel really confident that there's a lot we can do with diet, and that can include different versions of the FODMAP, either elimination diet or FODMAP gentle with enzymes that we can do on an experimental basis, so that if they can get their symptoms in a better place, again, they may not even need to see the gastroenterologist. So I don't personally need a formal IBS diagnosis. The diet can help people whether or not they have the diagnosis.
Very helpful. Well, thank you, Niki, for joining us. This was really just amazing. To everyone out there, thank you for tuning in today.